Council here in Alice Springs, and I oversee the day-to-day operations, which includes the needle syringe program, care and support program, which is our case management program, also a HEPLINK program and a health promotion program. And I'm here with Kim today.
Hi there. Hi, I'm Kim. I'm the nurse practitioner in the viral hepatitis clinic service at Clinic 34. It's sexual health and bloodborne virus in Alice Springs. So we support, care and treat people living with viral hepatitis in all the Central Australia region. In the hepatitis C space, I see people opportunistically who inject drugs. They may be referred by primary health or by NTARC, or seen opportunistically, and I also outreach to the local prison service. Clinic 34 is a secondary NSP site. I've also coordinated the implementation of the Kirby National Hepatitis C point of care testing program in Alice Springs, of which has supported the collaboration with NTARC testing. Firstly, before we start, I'd also like to acknowledge the Aranda people as the traditional owners of Badgewa, Alice Springs, where we're based. We're here today to talk about the incentivised hepatitis C testing and treatment that is carried out through the HEPLINK peer outreach project in Alice Springs.
So just to give some context to where the project is based, so Alice Springs is located right in the middle of Australia. And Alice Springs, it's a thriving town with a strong sense of community, also connection, and it's a very special place to live and work. The population, it's about 36,000 people, with 37.3% of them being Aboriginal and Torres Strait Islander.
For a more in-depth understanding of the context of people from and living in this region, we need to be aware of the key social determinants of health in this area, which are the geographic isolation, socioeconomic disadvantage that people experience, the housing and overcrowding, which is a significant issue here in town and in communities, remote communities, the intergenerational trauma, mistrust of services and the system in general, cultural and linguistic barriers, with English sometimes being someone's second, third, fourth, or even sixth language, as well as challenges with transport and mobility. These all create barriers and impact someone's ability to access services and healthcare.
So how does our incentivised hepatitis C testing treatment model work? So the HEPLINK peer outreach project is a peer-led approach to hepatitis C testing and linkage to care in Central Australia. It's a partnership between NTARC as a community-based service and Clinic 34 as a clinical partner. And the testing is carried out under the Kirby Institute National Australian Hepatitis C point of care testing program. And we have been doing the testing under both the Empower sub-study and now the main study. So the model has strong reach across surrounding remote communities, and we provide peer-led outreach to current and emerging at-risk populations. So the funding for incentives comes from different sources. So HEPLINK funds the project itself, including staffing and most of the incentives. Then we have the Empower sub-study, which comes with a $20 voucher, which we topped up with another $20 to make a $40 incentive for each test. Then Gilead Sciences provided a once-off bucket of funding towards incentives as well. And lastly, we've received some funding through the It's Your Right campaign towards incentives, which we used to top up the $40 incentives to a $60 incentive. For people who inject drugs for the duration of the campaign to increase the testing amongst this cohort. And then in the first 6 weeks of rolling over to Empower in September last year, when we started doing incentivized testing, we saw a really drastic increase in testing uptake. We think that although it was definitely due to starting to offer incentives, it was also equally because of an increase in capacity due to funding for the HEPLINK peer outreach project itself, which allowed for us to do weekly outreach sessions and also having more staff trained in being able to do the testing. And also, most importantly, that the project is peer-led. So we have 4 Happening Peer Outreach Officers who you can see here. So we have Troy on the left behind the plant. He is the lead Happening Peer Outreach Officer. Then we have Teresa, Paul, and Gandhi. So they are very much the driving force behind this model and the ones that does all the hard work to make it happen. Troy and Teresa are actually out on outreach as we're doing this presentation at one of the pharmacies here in town. And the success of the model is very much owed to them and a credit to the importance and value of a peer workforce.
So how does the incentivized model work in practice? Here, the peers do all aspects of the process, and that's everything from the initial conversations, testing itself, brief interventions, and any follow-up required until linkage to care is handed over to me at Clinic 34 if needed. The peers offer daily testing to needle and syringe program clients, which NTUC has found to be very important to be able to test this cohort, as they can catch them when they have an available moment. NTUC do weekly outreach sessions to a range of locations, as Karen just mentioned, and offer a flexible and low barrier approach where they can come to see individual clients at their homes or external services to get tested. They're focused on the clients, the community, and providing education, and to make sure that what they're doing is culturally safe in the work that they do. So these are some of the outreach sites, and the Priceline Pharmacy, that's where they are today. Troy and Teresa are at today. But other places that the NTUC team outreach to are the Aboriginal hostels, alcohol and other drug services, mental health services, the community op shop, farm, and the pharmacy. Also some ad hoc encounters where they bring people back to the NTUC office for testing inside an undercover space due to the summer heat.
So just a bit about the impact of the project so far. So approximately 89% of the participants identify as Aboriginal. The majority identified 1 or more risk factors. Like mentioned before, we have seen a significant increase in testing. To put that into perspective, initially before the peer-led model started and before we started offering incentives, over about 10 months, we did 37 tests when we initially started. And since commencing in September last year up until now, we have done 474 antibody tests and about 20 RNA tests. So we've seen a significant increase. We have had 4 people test positive for hepatitis C, and they have all been linked with treatment, if not the following day, that same week at Clinic 34 with Kim. And none of the people who tested positive were engaging with mainstream healthcare services, and they are likely not to have been screened or treated if not for this project here. In terms of challenges, we have seen that for some NSP clients, even with the $60 incentives, when we were offering that, it hasn't been enough for them to want to get tested. And we found that it was really about the relationship building and trust between them and the peers, and also having that low barrier approach and accessibility of offering the testing on a daily basis through our NSP, because we could sort of catch them if they one day did decide to get tested, which was the case for some of the ones that have tested positive for Hep C. Another challenge for us has been sort of finding sites to do outreach, because I guess all services have not been that responsive to having us there. So that's something that we're working on. And some of the things that we've learned has been the importance of collaborative care and also upskilling our peer workforce and building on existing community networks. And for us, being part of the Kirby Institute research study has ensured a rigorous framework around the testing, which has allowed for a well-managed project where the focus is not only on the number of tests that we do, but making sure that each client, whether they test positive or not, leave having had a brief intervention about hepatitis, safer injecting and other health info if they need that. Then a bit about what will we do differently if starting again. So probably focus on locking in more targeted outreach sites and also diversifying the services that we go to so we can broaden and increase our reach into at-risk populations.
So I guess the key takeaways from the project here in Alice Springs are, from what we've learned, is that lived experience really matters. Having an upskilled peer workforce driving a project for their community makes a significant difference. It's been huge. You also need the capacity to do the work, the capacity and the resources. You need the staff to be able to do that outreach and the education and the time that all takes. Practical outreach, make sure that you reach a broad range of people. And also, I've really valued the partnership that we've had between NTARC and Clinic 34. It's been strengthened remarkably. And also being part of the Kirby Institute research study has been invaluable for us as a community-based organisation when providing a wraparound service. And tips for others wanting to include incentives in their model of care. I guess what we would say is incorporate incentives into funding applications. So investing the time to explore and apply for funding is really valuable. And I know that Karen's really put a lot of time into that to get to where we are. And remember also that to be able to deliver a successful model, you also need the capacity to do so in terms of staffing. And if those staff are peers, that's even better. So that's our reflection on the program in Alice Springs. This collaborative approach has been really successful, and we'd also be keen to hear about your experiences and your services with incentives and your challenges and wins too. Thank you.
Thank you.
Fantastic. Thank you.